The topic that I've been asked to discuss with you all is where are we a decade, or in fact exactly 12 years and a bit, after what is broadly there called the Women's Health Initiative. The Women's Health Initiative is in fact, or still is in fact, a very large American study of postmenopausal women's health. And it had a number of topics, but within that initiative, there were two randomised controlled trials. And what we use, I'm not clear, is everything okay with me?
Seems like the audio's okay.
So you can hear me okay?
Yes, can hear you fine. Anyone else on the line, just obviously communicate with me through chat in the usual way if you've got a problem with audio. But I think we're okay, Henry.
I can't see you, Heidi, which you were clearly on the screen before. Okay, so the way in which the term the Women's Health Initiative is used in the context of our discussion this morning is particularly to describe in a shorthand way one of two randomised controlled trials of hormone therapy that was commenced back in about 1993, was ceased in 2002, and really turned the whole field of hormone replacement therapy on its head. And I hope that what I'm going to show you is that wasn't in any sense justified, and that hormone replacement therapy remains an excellent option and a safe option for the treatment of symptomatic postmenopausal women, and also for prevention of osteoporosis and osteoporotic fracture. I begin with my disclosures, and I do this purely as a formality. I used to receive honoraria and consulting fees for lectures, and was on the advisory board of several companies, in fact chaired the Pfizer Australian Women's Health Advisory Board. I've received NH and MRC support until a few years back, particularly for studies on the endocrinology of the menopause in latter years, but many other areas before that. And relevant to today's presentation, I was involved in the first World Health Organization scientific group on research on the menopause, and chaired the second one in 1994, and I'm going to refer to that in a moment. I have a series of references on this slide which really set in context current attitudes to hormone therapy. A very important one came from the American Endocrine Society rather than from a menopause society. An American Endocrine Society scientific statement published 4 years ago in the Journal of Clinical Endocrinology and Metabolism, with a large number of authors who really looked at hormone therapy in almost every conceivable area of medical practice, and where were its benefits, where were its risks. A group that was convened by Dick Santon, an endocrinologist with particular interest and expertise in the breast and breast cancer. Then the other three recommendations for reference all come from the International Menopause Society, updated recommendations published back in 2011, an issue of Climacteric, the journal of that society, published in 2012, and then a global consensus statement on MHT, as we'll abbreviate it, published last year in the journal Climacteric, and through which I will go at the end of this talk. I referred to the WHO scientific group meeting in 1994, and at that time two major issues were identified really relevant to the long-term use of hormone therapy rather than its short-term use which is its most frequent use for the management of symptoms. But if you were looking at using hormone therapy long-term, then there were two big issues: cardiovascular or coronary heart disease and breast cancer. And as summarised in this slide, in epidemiological studies, therapy with estrogens alone appeared to produce a marked reduction in the risk of coronary heart disease. And the main source of that information was an American study called the Nurses' Health Study, which showed that was true for nurses who chose to use hormone therapy and who were monitored long-term for many endpoints, including coronary heart disease. At that time, back in 1994, so 20 years ago, data on the use of estrogens plus progestogens was still sparse and inconsistent, and we weren't sure about that. And in terms of breast cancer, the use of estrogen alone for less than 5 years appeared to have no effect on the risk, and the addition of progestin to estrogen might be associated with an increase in risk, but that wasn't entirely clear at that time either. Let's look at those major diseases in terms of female mortality rates. This is data which is quite old, but I think it's still quite representative of the situation here in Australia. The ordinate shows rates per 100,000 women for mortality, and the abscissa is clearly and obviously age groups. And what you see is that the frequency of heart disease as a cause of mortality increases markedly in the 65 to 74 age group, and even more markedly in the decade after that. Whereas breast cancer mortality is much, much less at any time point when we look at those mortality rates. And lung cancer is somewhere around the same level as breast cancer. We tend to forget that heart disease is overwhelmingly the most important cause of morbidity and mortality in older men and in older women. Because of the data from the Nurses' Health Study, and because there was scepticism that that data might in fact only result from the fact that healthier nurses took hormone therapy and that the therapy wasn't really objectively beneficial for heart disease, the National Institutes of Health in the United States were persuaded within that huge Women's Health Initiative trial, which involved something like 180,000 American women, they were persuaded to do two randomised trials. One with combined continuous daily therapy using conjugated equine estrogen, Premarin 0.625, and medroxyprogesterone acetate, MPA 2.5, given continuously in women with an intact uterus. And the other trial was of estrogen alone in women who'd been hysterectomized, and that used CEE 0.625 alone. Those doses are somewhat higher than we would recommend now, but you've got to remember that it's about 20 years ago when these were fairly standard doses of hormone therapy that the trial was initiated. Now, both of those trials, when you really look at them, are clearly chronic disease prevention trials. They were done in older postmenopausal women. Average age in the two trials was about 63, so women were on average about 13 years past the normal age of menopause. 2/3 of them overweight or obese. We'll see that in a little more detail in a subsequent slide. Half of them were hypertensive or on treatment for hypertension, and half of them were past or current smokers. And it'll strike you that these are women at significant cardiovascular risk. There were two main questions that were posed. Does a standard regimen of the hormones usually used to treat menopausal symptoms reduce cardiovascular risk? Clearly a long-term study. And does the treatment increase breast cancer risk significantly? They were the two issues about which we were uncertain in settings like the WHO, the World Health Organization scientific group. Now, the WHI investigators curiously described their subjects for the study as predominantly healthy women. From an age point of view, of course, that's true. About 1/3 were less than 60 and 2/3 were over 60, as you can see in this slide. 2/3 of them in each of the trials were in the overweight category with a body mass index greater than 25, and almost half in the estrogen-only arm were obese, and about 1/3 in the combined continuous arm. There were about 16,000 women in total in the combined continuous study and about 10,000 in the estrogen-only study. So they were huge studies. Half of them were past or current smokers. The data for hypertension is shown there. Very importantly, as we will see in a little while, 1/4 of the combined continuous hormone therapy participants were past or current hormone users. In other words, given their ages at some time earlier in their lives, or even at the time that they were recruited, they were takers of hormone therapy. If they were on hormone therapy at the time they volunteered for the study, then they were discontinued for 3 months before being restarted. And in the estrogen-only, the hysterectomized group, almost half of them were past or current hormone therapy users. And that also raises the question of what risks that might be occurring in these studies are applicable to symptomatic women who wouldn't normally be past users of hormone therapy. Now, if we compare the subjects in the WHI trial and the women in the Nurses' Health study, you see that there are some important differences. First of all, if we look at the age range, I'm having difficulty getting the pointer to work. If you look at the age range, you see that the WHI enrolled women aged 50 to 79, most of them over 60. The Nurses' Health study enrolled women who were generally premenopausal or potentially perimenopausal. They were aged between 30 and 55. Most of the WHI, or at least half of the WHI volunteers were, as we've seen, past or current smokers. Very few of the nurses were. In terms of BMI, the volunteers for WHI were heavier than the nurses, and there was a difference in aspirin usage, which is probably not of any great relevance. In terms of hormone therapy regimens used, in WHI, the trial we're looking at used continuous combined therapy, whereas in the nurses study, which began back in the 1970s, unopposed estrogen or sequential treatment where progestogens were only given for part of the cycle were the commonly used regimen. And we'll see that that's actually quite pertinent to the subsequent results. And in terms of symptoms, they were the major reason that the nurses chose to use hormone therapy, and symptoms were largely excluded in recruitment for the WHI. The nurses was a purely observational study. About 120,000 nurses were recruited. They were sent a questionnaire every 2 years about their health. Nurses were chosen because it was thought that they'd be well informed about their health status, but there was no intervention. If nurses went on HRT, they did so for symptoms and at their own choice, where of course in WHI women who volunteered were allocated either to active therapy or to placebo in a 1-to-1 ratio. Now, I think what we've got to consider here, first of all, is there were some risks in WHI, and we're going to look at them in a moment, but what about the relevance of this randomised controlled trial to menopause management? I think you'd agree that an important criterion for the relevance of a randomised controlled trial of anything is that it is conducted in a population of subjects similar to those normally targeted for treatment. You wouldn't do a randomised controlled trial of a headache remedy in people who don't have headaches. And for WHI, this criterion is not met. And in fact, in the originally published paper back in July 2002, just over 12 years ago, the investigators said that the trial did not address the short-term risks and benefits of hormones given for the treatment of menopausal symptoms. And if people had taken notice of that statement, then I don't think the WHI would have caused too much of a problem. But they didn't, and everybody took it that the WHI trial applied to standard usage of hormones for menopausal symptoms. Short-term risks, short-term wasn't defined, but I generally take that to be less than 5 years. Some of you may remember the initial announcement of the results of that trial. First of all, the announcement was made by press conference before the study was published, and I don't remember any other large medical study that was the results of which were announced by a press conference before the results were actually published. The results were not published for 3 or 4 days after the press conference, and as you can imagine, there was just chaos here, where those of us who were practicing in the menopause area were besieged with questions about the results of the study when we'd not had any chance to properly evaluate what the trial was actually showing. And the public announcement, I think a malevolent announcement, was that menopausal hormone therapy causes a 26% increase in breast cancer risk. We'll see what that really translates to a little bit later. Such therapy also was reported to increase the risk of coronary heart disease, contrary to what was expected in this trial. So the initial announcement was quite spectacular and, as we'll see, I think totally misleading. The primary outcome of the WHI study was designated as coronary heart disease. And the first report said that the hazard ratio for coronary heart disease was 1.29. There were 286 cases of heart disease reported in the study, which was stopped after 5.6 years. And the hazard ratio for breast cancer was 1.26, that's the 26% increase, the heart disease 29% increase. But you see that the lower confidence bound of the 1.26 is 1.00, and that means that that result was not statistically significant, despite the fact that it was given a huge amount of publicity. Now, if you look at the data, the excess risk for 10,000 person years was 7 more coronary heart disease events and 8 more invasive breast cancers. That's 8 per 10,000, or less than 1 in 1,000 per year. How different that sounds from a 26% increase in risk. And I'm sure you all know also from often seeing the results of epidemiological studies that hazard ratios in the order of 1.25 or 1.3 are not very significant hazard ratios for most things, except when they're very common. So the absolute risk, and that's what should have been emphasised at the press conference and wasn't, was less than 1 extra case of breast cancer per 1,000 women per year, and remember that the base rate in a country like the United States or here is give or take about 3 cases per 1,000 per year in women not being treated with hormone therapy. So the rate went up from 3 per 1,000 per year to not quite 4 per 1,000 per year in women who were given hormone therapy. Very important data to put into perspective. The investigators also in their first paper said that there were no noteworthy interactions with age were found for the effects on coronary heart disease. In other words, the effect was just the same if you were 55 or you were 75. A bit hard to believe, but that's what they said. And it's noteworthy that the increased rate of cardiovascular disease was present across age strata. And we'll see that subsequent analyses of the data showed that that wasn't actually true. Now, as I've indicated, a major reason to undertake the WHI trials was the observation of a 40 to 50% reduction in cardiovascular disease risk as a result of taking hormone therapy, particularly in the Nurses' Health Study. And as I indicated, that was an observational study using data from mostly symptomatic American nurses who were treated around or shortly after the occurrence of menopause, 12 years earlier than the women in WHI. And such women, in general, are at low cardiovascular risk. As we pointed out, the WHI participants had a number of significant cardiovascular risk factors, including their age, much older than nurses, BMI, smoking status, blood pressure, and how long they were past menopause. And it was therefore very likely that many had subclinical atherosclerotic vascular disease. And therefore they're not subjects from whom we can extrapolate effects of initiating hormone therapy to the usual target population. And that again was something that was quite neglected. Now, the WHI results for cardiovascular disease were consistent with experimental observations from very elegant studies done in cynomolgus monkeys in the States. The female cynomolgus monkey was used as a model of menopause when her ovaries were removed. And in studies of atherosclerosis in cynomolgus monkeys, monkeys were fed an atherogenic diet, had their ovaries removed, and then were either replaced immediately with estrogen and progesterone, or that treatment was delayed for 2 years. And when treatment was initiated immediately after removal of the ovaries, there was a 70% reduction in cardiovascular disease compared with the monkeys where the treatment was delayed. So that gave rise to the concept of a window of opportunity. Soon after you lose estrogen, the concept is that there is a window of opportunity during which cardiovascular protection may be occurring if estrogen is given, whereas if you wait the equivalent of 2 years in monkeys, which is about 7 to 10 years in women, then estrogen would no longer be cardioprotective, primarily because of the development then of subclinical atherosclerosis and the loss of estrogen receptors in blood vessels. And in fact that was borne out in the WHI trial because there was no increase in cardiovascular risk in women who were less than 10 years postmenopausal, whereas there was a 70% increase, hazard ratio 1.71, for those women who were more than 20 years postmenopausal. Interestingly, in the estrogen-only arm, which sort of a bit reproduces the nurses' study, cardioprotection was noted in those who were 50 to 59 years old. So the two trials are very similar in their result in that endpoint. Russo et al., Russo was the main principal investigator for the WHI studies, published in the same journal in JAMA in 2007 in contrast to what I quoted from the original paper, that in the 50 to 59-year age group, there were low or no absolute excess risks of coronary heart disease, stroke, or total mortality, or actually, for that matter, breast cancer due to hormone therapy. And there were actually 10 fewer deaths per 10,000 person years. The WHO have provided an overall summary of their trials and the subsequent follow-up for a total of about 13 years observation last year in the JAMA. I haven't reproduced that in this study, but if you do look at it, it's, I think, an October issue of the Journal of the American Medical Association, you'll see that very few of the actual risks were statistically significant, and the 50 to 59-year age group is the age group where results are favourable. And they made some rather condescending statements about hormone therapy as listed there. Now, the field has changed a little bit in terms of cardiovascular disease, consequent on the study, on the publication of or the reporting of 3 other studies in particular. First of all, hormone therapy and cardiovascular events in recently postmenopausal women, a randomised trial published as part of the Danish Osteoporosis Prevention Study, DOPS, published in the British Medical Journal just under 2 years ago. This was a long-term study of Danish women to look at the effects of hormone therapy on osteoporotic fracture risk. But they collected carefully a number of other endpoints, including cardiovascular events and breast cancer. It was an open-label, randomised trial. In other words, half of the women were randomised to receive hormone therapy, the other half didn't get anything. The women were aged 45 to 58, and a requirement for entry into the study was that they were either very recently postmenopausal or perimenopausal. In other words, mirroring normal hormone therapy practice target women. 502 were on hormone therapy, and there were 504 untreated controls. And they were given what we, I think, now call, I've gone blank on it actually, it's a Novo Nordisk product, which is a triphasic product containing estradiol and norethistone acetate as the 2 major components. 2 milligrams of estradiol for 12 days, then 1 milligram of norethistone acetate for 10 days, and then 1 milligram of estradiol for 6 days. So it's a sequential form of hormone therapy. 400 odd women got that. There were 95 hysterectomized women. They just got 2 milligrams orally of estradiol. At inclusion, their average age was 50, and consistent with the selection criterion I mentioned, they were on average 7 months only postmenopausal. And the primary outcome was a composite of death, admission for heart failure, and myocardial infarction. And after 10 years of randomised follow-up, that primary outcome, the heart outcome, occurred in 18 of the women on hormone therapy and 33 controls. So there was a 50% protection from heart disease in the women given the sequential hormone therapy with estradiol and norethistone acetate. Mortality was also about half in the treated women, and breast cancer was about half in the treated women, although that result is not statistically significant. The investigators drew the conclusion that hormone therapy is associated with a significantly reduced risk of mortality, heart failure, or myocardial infarction without any apparent increase in the risk of cancer, and I didn't mention it, but there was no increase in the risk of venous thromboembolism or of stroke. So that's one trial criticised by the absolute purists in the field of randomised controlled trials, that it didn't really satisfy all the criteria for a proper RCT, but I think the results are substantial and very important in the context that was created by WHI. Two other studies have been in the news quite a lot in the last few years because people have been eagerly waiting for their results. One of them published the main results just very recently in the Annals of Internal Medicine, and that's KEEPS, or the Kronos Early Estrogen Prevention Study. And this again was addressing the notion of the window of opportunity. It was done to determine the effects of estrogen on atherosclerosis progression indices in early postmenopausal women. They recruited just over 700. They had to be within 6 to 36 months postmenopausal, and they were treated either with conjugated equine estrogen, a lower dose than WHI, 0.45 milligrams per day, or transdermal estradiol in a commonly used dose of 50 microgram per day, and they were given oral progesterone, 200 milligrams daily for 14 days, or placebo. And the primary measures, they measured a lot of things, but the primary measures were intima medial thickness and coronary artery calcium scores. And at the end of 4 years, there was no difference between the groups for cardiovascular endpoints. So it didn't matter whether they were given oral or transdermal estrogen or placebo. The rate of progression, which was very small, of the intima media thickness was no different between all three groups. And they concluded that 4 years of early menopausal hormone therapy did not affect atherosclerosis progression. Now, of course, these were women at very low risk of cardiovascular disease and women with low risk, therefore, of atherosclerosis and, therefore, of atherosclerosis progression. So I don't think the conclusion puts doubt on the benefit of estrogen. It just says if you've got somebody at low risk and in whom heart disease is progressing very slowly, it's very hard to see any difference. In fact, in the coronary artery calcium score area, the women on estrogen, on average, had not statistically significant, but lower coronary artery calcium scores at the end of the 4 years than the women on placebo. There were expected effects otherwise of the estrogens. The oral estrogen reduced low-density lipoprotein cholesterol, and I think that they were the main difference. That was the main difference seen. The other study, which hasn't been published yet, was called ELITE, Early versus Late Intervention Trial with Estradiol, and it's been done to determine, again, whether the effect of estradiol on intermediate thickness progression depends on the time since menopause. Here now they recruited just over 600 women and divided them into two roughly equal groups, women either less than 6 or more than 10 years post-menopausal. And they were given oral estradiol, 1 milligram a day, plus vaginal progesterone. And those results have not been formally published. There have been some presentations at meetings, as far as I'm aware, which have reported a slower progression of IMT in the early postmenopausal women, but I can only say that the full results of this trial are awaited with interest. We'll come back to the cardiovascular indications in terms of hormone therapy towards the end of the talk. Now, what about the other major issue, the breast cancer issue? As I indicated, the press conference announced a 26% increase in breast cancer risk, and that was the major reason for widespread anxiety at the time of the press conference and afterwards, and the abandonment by many, many women of their hormone therapy. And in fact, I think there were, in the United States, 30 to 40% of women, even more than that, on hormone therapy when the WHI results were announced, and that dropped to about 5 or 6% over the subsequent 2 or 3 years. There was an enormous downturn in hormone therapy use, and I hope you'll agree, for not very good reason. It's therefore important to examine the risk critically in terms of its relevance to normal menopause management. I mentioned to you earlier that 3/4 of the participants in the combined trial had never received hormone therapy, but 1/4 had. And even in the very first paper published, the investigators, in a one-liner, which you really had to read the paper carefully to see, said there was no significant increase in risk after 5.6 years in the hormone-naive participants. Why didn't they announce that properly at the press conference? Because the only increase in risk was really in the women who had had prior hormone therapy. Let's look at those data which the investigators published about 4 years later. On the left-hand side here is invasive breast cancer rate in the non-prior hormone users, and on the right-hand side, those who were prior users. The blue line is the estrogen plus progestin arm, the red line is placebo, and the ordinate has cumulative rates of breast cancer and the abscissa time in years on therapy. If we concentrate on the left-hand side of the slide first, you see that the red line is above the blue line until about the 4-year or 4.5-year mark. In other words, there's a bit less breast cancer in the estrogen plus progestin arm than in the placebo arm in the first 4.5 years. Then the lines cross, and if you look at the summary statistics for the whole 7-year period, there's no statistically significant increase in breast cancer risk in those non-prior users who amounted to about 6 of the 8,000 women actively treated. On the other hand, if we look on the right-hand side of the slide, we see that the blue line is actually quite similar to the blue line on the left, but the placebo arm rate of breast cancer falls away. Now, it does appear very likely that very long-term hormone therapy does increase breast cancer risk, and that when you stop, the risk goes back to baseline. And I think that that's what's reflected here, that after 2 to 3 years, the rate of breast cancer in the prior users starts to fall, whereas in the ongoing treated group in the blue line, the rate is about the same as it was in the non-prior users. So this is a very important breakdown of the study. The WHI investigators justify not drawing much attention to this on the grounds that one shouldn't use subgroup analysis. In the estrogen-only arm, the risk was actually lower in estrogen users than in placebo users. Not quite statistically significant at the end of the trial. Actually was statistically significant again in the non-prior users, and other studies had shown that with estrogen alone it took quite a while before breast cancer risk increased. Now this is the summary data from the WHI published in 2011 for invasive breast cancer. Notice that the placebo arm again is the red line, and the breast cancer, that the actively treated estrogen alone group is the blue line, and the blue line is below the red line whether we look at the whole study on the left-hand half of the graph or the post-intervention phase only. On the right-hand side, the effect of estrogen alone to reduce cancer risk, and that is statistically significant at the end of this follow-up period, is an effect which is persistent. I won't have time really to go into why that should be the case, except to say that there is experimental evidence that if you have breast cancer cells in the breast which haven't seen estrogen for a long time and are then exposed to estrogen, as would have been the case in the estrogen-only arm of WHI, then those cells undergo apoptosis, and instead of being stimulated to grow, they're turned off. And that, I think, is a very satisfactory explanation of why the risk in the estrogen-only arm is less, whereas in estrogen plus progestin-exposed breast cells, that doesn't occur in the same way. What can we conclude from the WHI in the breast cancer area? That combined HT may increase breast cancer risk after 5 to 7 years. It looked as if that's where the curves were going. The investigators haven't published the separate results for the long-term follow-up. There was no evidence of a risk increase before that. There is some evidence, it's pretty tenuous, from publications that I don't have time, nor do I think it's relevant to review them, that time since menopause might be important, that women who start therapy closer to the time of menopause are more likely to have an increase in risk. Well, just think back to the Danish osteoporosis prevention study where breast cancer risk was actually less in those women who were started close to menopause. And estrogen alone in hysterectomized women may decrease breast cancer risk in the first 5 years, but ultimately there's an increase in risk. What can we say if we look at the randomized trial and observational studies of breast cancer? First of all, it's not possible to make an overall statement about the risk of hormone therapy. It depends so much on the individual characteristics of the individual woman. It has been estimated that for Australian women in the early postmenopause, the absolute increase in risk may vary from none at all to 12 additional cases per 1,000 women per 5 years. Remember I said that the baseline rate was about 3 per 1,000 per year, so 15 per 1,000 per 5 years, so that you see that the risk varies from nothing at all to not quite a doubling in risk, which would particularly probably be seen in lean women, potentially those particularly treated with MPA or perhaps with norethisterone. The risk may increase after 3 years in those at highest risk, and we clearly need to assess risk as part of our overall consideration of benefit and risk when we're starting somebody on hormone therapy. Now, to get to the real kernel of the question put at the very beginning, what lessons have we learned? Well, I think the first and obvious lesson is that treatment trial results shouldn't be released by press conference before publication. Particularly, the use of relative risk rather than absolute risk can give rise to grossly distorted perceptions of treatment effects. 26% increase versus less than 1 in 1,000 per year, they're very different concepts. For coronary heart disease, the results don't apply across age strata as originally claimed, and in fact, in the 50 to 59 year group, there may be evidence of cardioprotection rather than increased risk. In 2002, as I said, the JAMA paper said that the increased risks for cardiovascular disease and invasive breast cancer were present across racial, ethnic and age strata. In the 2007 paper, there were no significant increases in risks for women aged 50 to 59, so a complete contradiction of the data from the same investigators in the same group of subjects. Increases in risk for coronary heart disease, stroke and global index events in some older age categories were noted. And you'll see that if you look at the summarised results, as I say, last October in the JAMA. Some of the WHI investigators can't get away from their original conclusion, and in a review published in the Journal of Obstetrics and Gynecology in last year, you find them saying, as noted in the original Women's Health Initiative, estrogen plus progestin publication, the increased risks of CVD and invasive breast cancer were present across all age strata, even though they previously said they weren't. And I would like to just emphasise that the conclusions from the use of oral CEE and MPA may not at all apply to transdermal estradiol and progesterone or dihydrogesterone as the progestin. And we'll perhaps refer to that momentarily a little bit later. It's important to recognise that there were very high dropout rates in the combined study, 42% for the hormone therapy, 38% for placebo, which raises a lot of questions about the interpretation of the results, and strict epidemiologists would say, well, that just makes it an observational study, not a proper randomised trial. Importantly, and as I think Sonia alluded to towards the end of her presentation, the population was not selected as being at increased risk of fracture, despite which hormone therapy decreased the hip fracture rate from 15 per 10,000 per year to 10 per 10,000 per year. So 5 fewer fractures per 10,000 women per year. And it's the first trial with definitive data supporting the ability of postmenopausal hormone therapy to reduce fracture risk. And that was also true for the estrogen alone arm. Another benefit, apparently, was that hormone therapy decreased the risk of colorectal cancer from 16 to 10 per 10,000 per year. Notice that reduction of 6 per 10,000 is in the same ballpark as the increase of 8 per 10,000 in the rate of breast cancer. And similarly, there was actually a decrease in the rate of development of diabetes in the treated arm. In the light of the fracture data, it was predictable that an increased rate of fracture would be seen in women who prematurely discontinued their treatment, and there are at least 2 published reports which show quite a substantial increase in hip fracture rates in women who stopped their hormone therapy with a comparable group who maintained their therapy. Whether an increased risk of coronary heart disease will occur hasn't yet been documented. I think it will be. The recently published results from the Danish study suggest it may, and there's one study published a few months ago with a lot of assumptions suggesting that indeed there has been a significant increase in coronary heart disease occurrence and death in women who stopped their therapy. The investigators cautioned that this trial does not address the short-term risks and benefits of hormones given for the treatment of menopausal symptoms, and yet despite that, it was assumed universally that they were applicable to symptomatic peri- and early post-menopausal women, a very important distinction. The results of the estrogen-only trial were much more favourable. They showed cardioprotection, they showed reduction in breast cancer risk, and similar effects on fracture risk. I didn't refer to the effects on venous thromboembolism. The risk of that was about doubled in both the trials, but it was increased a bit more in the combined continuous trial. But I must say that those data from estrogen alone in hysterectomized women give one a lot of confidence about particularly prescribing estrogen alone for somebody who's been hysterectomized. Because of the difference between the 2 trials, questions were raised about the role of MPA, and recent data, particularly from a French group but from 2 other groups also, suggest that progesterone and dihydrogesterone are safer progestins, and a big observational study of French women teachers suggested that up to 8 years follow-up, women who took progesterone along with their estradiol had no increased risk of breast cancer, whereas women who took the synthetic progestins that are commonly used in menopausal hormone therapy after 6 to 8 years had about a doubling in their risk of breast cancer. So the type of progestin may be very important. Unfortunately, in Australia, progesterone is still not readily available. You have to become an approved prescriber to prescribe it, but hopefully there will be an increasing trend for progesterone to become available, or dydrogesterone, as there's quite a lot of evidence that they're safer for breast cancer and for heart disease. The conclusions of the WHI investigators were that the risk-benefit profile found in the trial was not consistent with the requirements for a viable intervention for primary prevention of chronic diseases, and the results indicate that the regimen should not be initiated or continued for primary prevention of coronary heart disease. Now, I think that that's still a valid conclusion for combined continuous hormone therapy with conjugated estrogen and NPA. Whether it's true for transdermal estradiol with progesterone is a totally different question, and it's very interesting that with the amount of data suggesting cardioprotection in early postmenopausal women, that people still don't want to recommend hormone therapy for cardioprotection in those women. I'd like finally to briefly go through the global consensus statement. Menopausal hormone therapy is the most effective treatment with benefits outweighing risks, particularly in women less than 60 or less than 10 years since menopause. Are we okay, Heidi?
Yeah, no, we're good.
Hormone therapy is effective and appropriate for osteoporosis-related fracture prevention in the same groups. I would point out that the TGA wouldn't support that statement. I think the national osteoporosis groups have probably changed their view about that, but I think the WHI certainly showed us that osteoporotic fracture can have its risks reduced, and because the occurrence of bone loss postmenopausally is primarily related to estrogen deprivation, it is logical to use hormone therapy in those less than 60 and less than 10 years since menopause to preserve bone mass and reduce fracture risk. Standard dose estrogen alone may decrease coronary heart disease and all-cause mortalities in the same group. Combined hormone therapy with CEE and MPA is neutral, but it may well be that other forms of therapy are protective. Local low-dose estrogen should be used when the symptoms are predominantly only urogenital or vaginal. Estrogen alone is appropriate post-hysterectomy, and in general, progestins are required if the uterus is intact, and clearly the option of using hormone therapy is an individual decision. And finally, venous thromboembolic and ischemic stroke risk increase with oral MHT, although the absolute risk is rare under the age of 60. There is at least one very large observational study which suggests that stroke risk is not increased with doses of transdermal estradiol of 50 micrograms or less per day. Breast cancer risk over the age of 50 is a complex issue, but seems to be primarily associated with the addition of a progestin, and again, query the nature of the progestin. The risk is relatively small and decreases after treatment is stopped. The dose and duration of hormone therapy should be individualized. In premature ovarian insufficiency, systemic hormone therapy is recommended until the average age of natural menopause. So if a woman has a premature menopause when she's 32, I think it's very important to recommend strongly that she take hormone therapy until she reaches the age of about 50 or 51. She may elect to go longer than that. The use of custom compounded, so-called bioidentical hormone therapy is not recommended, and it's recommended against by all major societies. And the International Menopause Society, from their consensus conference, concluded that current safety data don't support the use of menopausal hormone therapy in breast cancer survivors. I won't amplify that statement except to say that I'm not necessarily in agreement with it. I hope that that's given you a proper concept of WHI, of the untold damage and the totally unnecessary damage which it did, and I hope that it will give you the information to deal with questions about WHI when you're seeing GPs in their practices.